Good morning. Good morning, everyone. My name is Emil. I'm Dr. Emil Tan. I'm the head and senior consultant at Singapore General Hospital and the National Cancer Centre, Singapore. I lead the Department of Colorectal Surgery. With me today are four of my distinguished colleagues, Dr. Aaron Seah, Dr. Kelvin Lee, Dr. Lin Wenjie, and Dr. Lionel Chen. We're here today to talk to you about colorectal cancer and why you should be aware. Now, colorectal cancer remains one of the top killers in Singapore. But unlike a lot of other cancers, there's a long run-up stage to progression to cancer, and therefore it is detectable and it's also preventable. When detected early, 95% of people can experience full cure. However, in Singapore, despite being a highly developed country, we still find that over 60% of our patients are rather advanced in stage when we detect the cancer. As such, the chance of cure is a little bit lower than what we hope it to be. Through today's webinar, we hope to create more awareness on colorectal cancer and to encourage everyone to come for screening. So without further ado, let's have Dr. Seah give the first talk. Any early signs, when should I be worried?
Hi, good morning, everyone. I'm Aaron. I'm actually one of the junior associate consultants in the Department of Colorectal Surgery, Singapore. Today I'll be presenting a topic on any early signs and when should I be worried for colorectal cancer. So first we'll start with what is colorectal cancer. So it's the cancer of the large intestines or the rectum, which is the passageway from the colon all the way to the anus in all of us. In most people, it develops gradually, like what Prof. Emil has said, as a prodrome, and it slowly develops over several years. It usually starts as a small benign polyp, as seen on the bottom left of the screen, as a normal growth of the inner mucosa of the colon, and eventually it progresses in size and has some changes which develops into cancer. So let's start with how common is colorectal cancer. In the worldwide, it's actually the third most common cancer, and has about a 10% incidence reported in 2020. It's also approximately 10% of all cancer-related deaths in the world. In Singapore, it is actually the second most common cancer, both in male and female. In males, it's about 16.3%, as compared second only to prostate cancer. And in females, it is quoted to about 12.9%, second only to breast. So what are the symptoms for colorectal cancer and what should we be wary of? So sometimes they may present as actually a change in your bowel habits. Instead of usually passing motion once every few days, it may actually become weeks or even prolonged duration. Other things will actually just be blood in the stools, unexplained weight loss, or of course, it may also be a persistent abdominal discomfort. In textbooks, they also do mention that sometimes some patients present with incomplete emptying, unable to completely pass out all their motions. Some also say that they have a change in the stool caliber, which get more thinner stools instead of a usual large sausage-shaped stools. Of course, unfortunately, there are actually no really early signs of developing colorectal cancer. What I described previously mainly appear in the later stages or once colorectal cancer has become relatively large. For majority of early colorectal cancers, they all are usually asymptomatic, where there's totally no symptoms and they go about their usual bowel habits, usual daily lives. So so we would strongly suggest not to wait for these signs before things happen. How do we take control of our lives early and start preemptively doing something about it? Some modifiable risk factors which you know about would also be, of course, trying to lose weight, not be obese, avoid a sedentary lifestyle, try to go out, do more exercise. Some of the dietary habits which are risk factors for colorectal cancer will be excessive intake of red meat. Of course, alcohol and smoking is also strongly not advised. But the most important way besides modifying these risk factors is, of course, to go for colorectal cancer screening. In Singapore, we have quite a number of ways to go for screening. So this includes doing a stool test, which I'll talk about and elaborate a bit on later on. Going for a CT colonography, which is a scan to see and detect polyps in the colon. And of course, to go for colonoscopy, which later some of my colleagues will elaborate greater on in the next few talks. So some of the indications to go for screening in Singapore: when you're asymptomatic, totally no symptoms, we advise to go for screening when you're above 50 years old. If you have not done a fecal immunochemical test within the last 12 months, or you have not done a colonoscopy within the last 10 years. I'll elaborate a little bit more on the fecal immunochemical test. This actually, how this is done is usually get mailed this small ampule, 2 of these, within your mailbox or however you choose to get it. You collect your stool on a clean toilet paper, and subsequently, once you have your stools, you untwist the cap and you poke your own stool samples at 6 different locations. After that, you simply put it back in the ampule, you shake it, and then you can mail it off with a proper details. Of course, this will be done with 2 separate samples. It'll be sent to a Singapore Cancer Society, and you should expect to hear it back with results within 6 to 8 weeks. Very simple, very straightforward. So for those who are interested in this, which I assume all of you are since you're listening here now, how do we get this test? This test can actually be easily obtained through online means, actually, through the Singapore Cancer Society website. Those who are interested, the link is at the bottom of the screen. It's actually going at no additional cost today, and then they'll send it straight to your mailbox at your house. For those who are not so savvy, there are actually other means to get it. This can actually be easily obtained from either multiple pharmacies in Singapore, Unity, Guardian, even You Yang Sang. And of course, you can already go to the Singapore Cancer Society office itself. So thank you for your attention. That's mainly what I have for you regarding the signs and symptoms and a little bit about the FIT screening. For now, I would actually like to pass on your attention towards Dr. Kelvin Lee, who's my close colleague. Today, he'll be talking about how is colorectal cancer diagnosed and can it actually be prevented. Thank you.
Hey, hi, good morning, everybody. My name is Kelvin. Indeed, thank you for taking time off your busy schedule to join us on this webinar. It is my pleasure and honor to share with everyone here a little bit more about colorectal cancer. And specifically today, what I would like to share about is how is colorectal cancer diagnosed and how can we prevent colorectal cancer? All right. So without further ado, let me begin. Okay, so colorectal cancer is primarily diagnosed via colonoscopy and biopsy. So when we say biopsy, it means taking samples of the tissues to send for further histological testing. So I think maybe some people who have some of our members here, some of people, members of public here who have had colonoscopy, and probably some who wouldn't have. And so I would just like to take this opportunity to share a little bit more on how colonoscopy is done. So we talk about colonoscopy. Basically, what we're saying is that we're introducing a little cable through your backside, through your anus, into the interior of your colon, and to visualize the inside of the colon directly using this equipment, what we call the colonoscope. And so by diagnosing the interior of your colon, we can then have dual functions. One is what we call diagnostic. Diagnostic in the sense, meaning that we can see what's going on in the interior of the colon and check if there's any tumorous or tumor growth within the colon itself. And the second function of colonoscopy will be therapeutic in the sense that it can help to carry out certain interventions, for example, removal of small polyps or even removal of medium-sized benign polyps where applicable. So before anyone goes for the actual colonoscopy, there is a bit of preparatory work to be done. So for example, you need to have some dietary preparation. In the 3 days leading up to the colonoscopy, you have to reduce your fiber intake, which means that you have to reduce the amount of fruits and vegetables that you take in the 3 days leading up to the scope. And the reason is actually very simple, because high fiber food will actually cause your stools to be bulky, to be a little bit more, higher amounts than usual. And this will affect how much the visualization during the colonoscopy. So in other words, by reducing the amount of residue in your diet leading up to the scope, it will allow us to see the interior of a colon better during the colonoscopy itself. And then, just before, or rather on the night before I go for colonoscopy, you will have to do this bowel, what I call bowel preparation, which involves taking 2 packets of laxative powder. In this case, what we commonly use is this Fortune's powder, which is 2 packets of powder that has to be mixed with 2 liters of water and then to be finished within 2 hours. So this will result in you visiting the toilet up to 8 to 10 times. And this is a very important step in the preparation because it's basically what it does is to clear your intestine, remove all the fecal matters from within the colon so that when we actually do the colonoscopy, we can see all the lining of the colon very clearly. Because if there's a lot of stools, we won't be able to see clearly. This will in turn affect the accuracy and even the safety of the colonoscopy itself. And often a lot of patients will actually complain that this is the most troublesome and most difficult part of the colonoscopy itself, not the actual colonoscopy, but having to visit the toilet 8 to 10 times before the colonoscope itself. And for some of our members of public, some people who may be on medications for chronic illnesses, there will be a need to review the medications they are on, and we may need to stop certain medications before the colonoscope. Namely, we have to temporarily suspend the blood thinners prior to the scope so that the scope can be done safely and the risk of bleeding caused by the scope will be minimized. The actual process of the scope actually is a very simple, relatively simple and quick procedure. Usually it's done under sedation. That means some medication will be given to you to put you to sleep so that the scope itself is not so uncomfortable. Do take note that this is not general anesthesia. So you are still breathing on your own, and you do not need any tube down your throat to help you in breathing. Rather, you're still breathing on your own and you're half asleep, or rather asleep during process of colonoscopy. The whole procedure is only about 15 to 20 minutes, depending on whether polyps are found, how many polyps needs to be removed. And thereafter, you need to rest in hospital for 1 to 2 hours before you can go home. There's no need for any overnight stay in the hospital. So the whole process of colonoscopy actually is quite simple. And now I just want to talk a little bit about prevention. Okay, so I mean, at the end of the day, when we talk about colorectal cancer or any cancer for that matter, prevention is always better than cure. And so to understand how we can better prevent colorectal cancer, we need to then take a look at what are the risk factors that predisposes us to colorectal cancer. So the fact is, all of us are at risk of developing colorectal cancer, and we all have certain risk factors. And broadly speaking, these risk factors can be divided into non-modifier risk factors and modifier risk factors. So non-modifier risk factors are like the deck of cards that you're dealt with. You can't really do much about it. And these are the things that you have to, there's not much you can do about it, and we have to just deal with it accordingly. Whereas for the modifiable risk factors, these are the things that we are of interest. These are things that we can do certain interventions to help mitigate the risk and hopefully prevent the development of colorectal cancer. So specifically, when it comes to modifier risk factors, what we're talking about are things like, for example, smoking, dietary habits, alcohol, and of course, lifestyle habits. So when we talk about obesity in itself is a known, well-studied risk factor for colorectal cancer. Obesity, as defined by BMI of 30 and above, is actually associated with up to 40% increase in risk of developing colorectal cancer. And among our patients with colorectal cancer, the fact is up to half have high BMI of more than 25. And we also know that not just that obesity predisposes you to colorectal cancer, but we also know that obesity in itself is associated with poorer survival rates compared to colorectal cancer patients who are of normal BMI. And so, by reducing your BMI to a healthy range of less than 25, it can actually help prevent colorectal cancer, as supported by many large-scale studies. Another important risk factor that we need to be mindful of is our lifestyle habits. The fact is, sedentary lifestyle is associated with increased risk for colorectal cancer up to 30 to 70%. And so conversely speaking, by maintaining active lifestyle, engaging in healthy activities, going out for example, going for regular walks, jogs, maintaining, having a regular exercise habit, this can actually help to prevent colorectal cancer amongst many other illnesses. And now we talk about dietary habits. As the previous speaker, Dr. Aaron, has already alluded to, certain food is actually associated with increased risk of developing colorectal cancer. one of which is red meat. So when we talk about red meat, what we are referring to is actually beef, pork, and lamb. And high intake of such meat is associated with increased risk of colorectal cancer of up to 30%. Another important group of food to watch out for is actually processed meat, which is of course commoner in the West. So things like bacon, sausages, and even luncheon meat is associated with increased risk of up to 40% of developing colorectal cancer. So the recommended intake for red meat is about 500 grams of wheat per week. So for example, if you take a slab of beef steak of about 250 grams, that means you're allowed up to 2 slabs of beef steak per week. And when it comes to processed meat, the recommendation is to limit the amount as much as possible. So another important risk factors for colorectal cancer will of course be alcohol and smoking. Excessive alcohol consumption, as defined as more than 3 drinks per day, is associated with increased risk of up to 25%. And there's also a irrevocable strong link between smoking and colorectal cancer, where chronic smoking is not just associated with an increased risk of developing colorectal cancer, but also a poorer survival rate. So when we talk about non-modifier risk factors, we are referring to things such as your age. So the fact is, the risk of developing colorectal cancer increases with age, and therefore we strongly encourage. When you reach a certain age, we will strongly encourage colorectal cancer screening. So in our local context in Singapore, we strongly encourage screening for colorectal cancer to begin at 50 years. And that's for average risk population. If you're of higher risk, for example, if you have strong family history, you actually strongly recommended to begin screening at an earlier age before 50 years. Other non-modifiable risk factors include your risk factors, your family history, whereby if you do have a strong family history of colorectal cancer among your first-degree relatives, it is a known risk factors. And of course, if there's no genetic syndromes or changes or abnormalities within your family, this will also put you at increased risk of developing colorectal cancer. In some of the well-known, well-studied genetic syndromes, including syndromes such as familial adenomatous polyposis and Lynch syndrome. So to sum it up, when it comes to prevention of colorectal cancer, these are the 5 no's, right? No smoking, no excessive drinking, no to obesity, no to sedentary lifestyle, and no excessive red meat and processed meats. And then I would just like to end off my talk here with just one final slide on colonoscopy. So when it comes to prevention of colorectal cancer, actually colonoscopy can, in theory, help to prevent colorectal cancer. And how this works is that the fact is most of colorectal cancer arise from existing benign polyps. In other words, most colorectal cancer first begins as a benign polyp, and then as they grow bigger, they will turn cancerous. And this process of benign polyp turning cancerous typically is over a stretch of 5 to 10 years. So this has important implications for us and for you. The fact is, there is a detectable pre-malignant phase. There is a period of time where before the polyp turns cancerous that we can intervene. And this period of time is relatively long, 5 to 10 years. So by intervening before the polyps turn cancerous, in other words, to do a colonoscopy and remove the polyps while it is still in the benign phase before it turns cancerous, this in itself helps to prevent the development of colorectal cancer. So we really cannot stress the importance of colonoscopy in both diagnosing as well as to some extent in preventing colorectal cancer. And so with that, I end my talk, and I'd like to next pass on to the next speaker, Dr. Lin Wenjie, who will be speaking about colorectal cancer, the treatment of colorectal cancer specifically. Thank you.
Hi, good morning, everybody. Thank you for joining us today. I'm Wen Jie, one of the staff on the Department of Colorectal Surgery in Singapore General Hospital. And today I'll be talking about treatment of colorectal cancer, or if it can be treated at all. We've been through this a little bit, but there are a couple of photographs here important to drive home the point. Colorectal cancer is actually a malignant growth of the inner lining of the colon. And like Dr. Calvin has mentioned before, this takes 5-10 years to develop and usually starts from polyps. Why is colorectal cancer important in Singapore? It is overall the most common cancer in Singapore across both genders. And also, the incidence of colorectal cancer is increasing over the years, with roughly about 1,500 to 2,000 new cases diagnosed per year. Whether they end up with treatment or not, that's besides the point. Also, more importantly, it affects productive years of life. You can see in the males, they start being near the top of the list from 30 years old onwards. And this is an important uh, fact to remember, because colorectal cancer does not just affect the elderly population like most other cancers. Colorectal cancer comes in many stages. I'm sure most are aware of stage 1, stage 2 to stage 4. In general, stage 1 and stage 2 are local within the colon or rectum, depending on the depth of invasion and size of tumor. Stage 3 cancers start to spread towards the lymph nodes, which are the draining stations around the colon and the colorectal cancer. And stage 4, we call it stage 4 when it's spread to the other organs. So in terms of why is this important again? Because looking at the stages of colorectal cancer, the earlier it's detected, the earlier it is treated. With an earlier stage, survival is better. The chance of it recurring is lower. So outcomes are better if you are diagnosed early and treated early. In terms of the surgical treatment of colorectal cancer, I'll run through it of the options that we have. Polyps is very possible using a colonoscopy. During colonoscopy, when we detect polyps, we are able to remove them fully. And some of these times, these polyps contain cancers. And it depends on what the biopsy results of the cancers are. In very favorable biopsy results, small cancers in polyps, sometimes endoscopic removal may be sufficient treatment already. Some more photographs of removal using the scope. Next, moving on to transanal surgery. This is a specialized procedure that we do perform at Singapore General Hospital. It is usually limited for early cancers within the rectum, where we put in a port through the anus with the help of long instruments and a camera. We remove cancerous polyp in the rectum through this minimally invasive means. Again, a further discussion with your specialist will be required to see if somebody with such a diagnosis would be amenable for such a treatment. In a more traditional sense, we talk about surgery for colorectal cancer. The gold standard these days, and we perform 90% of our cases in Singapore General Hospital using minimally invasive methods. This is either laparoscopic or robotic-assisted surgery. In terms of laparoscopic surgery, we introduce a camera into the abdominal cavity with long instruments again introduced through small cuts. And with these methods, we can remove the colon safely and join everything back together if possible. And the final results can be quite impressive with very small wounds seen only. In robotic assisted surgery, the Da Vinci robot that we have can be employed to assist minimally invasive surgery. Such surgeries are very, very subspecialized, and discussion with your provider will be necessary. The benefits of using a robot is clear, especially for very low rectal cancers. Overall, compared to open surgery, minimally invasive surgery has the advantage of a shorter hospital stay, less pain and quicker recovery and back to function. Often, chemotherapy is also discussed in the treatment of overall treatment of colorectal cancers. Generally speaking, it is limited to Firstly, after surgery for cases which are stage 3 or high-risk stage 2, for stage 4 colorectal cancers, chemotherapy may be the first-line treatment. And for rectal cancers, there is special consideration for chemotherapy as well as radiation prior to surgery. Discussions with your provider will be necessary for this. All in all, colorectal cancer is very treatable with very good outcomes. So please do not hesitate to ask us any further questions that you have. I guess we'll be opening the Q&A from now on. Thank you.
Okay, hi. So my name is Aaron here. So I think the first question they ask is how long does it take for rectal polyps to turn cancerous? This is actually quite a good question. What happens is when we deal with polyps, there are certain factors that come into play. First thing first will be what type of polyp it is. There are many different types of polyps, whether they are just proliferative or whether it's adenomatous. After removal, we usually will send the polyp for testing under microscopic evaluation, histology. And based on those, we can actually then decide how likely they are to turn cancerous or whether they are just benign polyps. That really depends on what histology, what is the microscopic findings of these polyps, and also at that onset when it was first diagnosed, whether or not it was completely removed. If in general, if they've been completely removed and it's actually a benign polyp, usually we do another repeat scope in about 3 years' time, just to survey to make sure that there's no further recurrence in that area and also in the rest of the colon. Yeah, I hope that answers the question.
Okay, hi. Yeah, so this is a very very cents and dollars practical question. How much is colonoscopy? Okay, okay, obviously a lot of patients will ask that, and rightly they're concerned with that. And my usual reply to that is that I don't want to give you wrong answers. I don't want to. Usually we'll let the clinic assistant handle it. So okay, my point here is that I'm not sure the exact cost because the cost will also vary according to what's your status. Are you a subsidized patient or private patient? But my important point I want to share is that most of the cost of the colonoscopy can actually be claimed from MediSave. So the out-of-pocket payment is actually not substantial, not a significant proportion. All right. But for the exact cost, I don't want to give misinformation. So I think probably try to find out from other sources. But the second part of the question is, does it require admission? The quick answer to that is no. So as I shared, generally the scope procedure is about 15 to 20 minutes. Then you just need to monitor for about 1 to 2 hours, and then you can go home. No need to stay overnight in hospital. It is not meant for as an inpatient procedure by and large. Yeah, thank you.
Actually, I helped Dr. Lee out. I'll answer the question for him. Okay, so actually colonoscopy is actually relatively cheap, very affordable. It's between 1,500 to 2,000 in most restructured hospitals. Okay, it does vary depending on whether you find polyps or whether you need to have an extended procedure or not. But it's generally around there. If you go to a restructured hospital, there's no doctor fee, there's no surgeon fee, unlike in the private. Therefore, it is really very cheap. It's generally under 2 grand. And on that, it depends on whether you're on full subsidy, which is 80%, or 50% at the C-class rate, and so on. So you can have, between 50 to 80% of your bill covered by subsidy, depending on your class, and then the rest will be through the MediSave, and there's a small out-of-pocket charge as well. Okay, but you will get financial counseling when you go for it. Thanks.
Oh, thank you for this question. It's very specific to inflammatory bowel disease. Inflammatory bowel disease, the short answer is yes, it can predispose to cancers due to the nature of disease where it's a chronic inflammation, and this can lead to cellular change and leading to colon cancers. I will take it on the point of there are 2 types of inflammatory bowel disease, but what we are more concerned about is something called ulcerative colitis. These patients with ulcerative colitis have inflammation of the entire colon, and there will be an inevitable progress towards changes in the cells towards cancer, which is why screening in these group of patients is very important, and you should be seeing your regular gastroenterologist for that. And with any early change in cells, there will be a consideration for removal of the entire colon. Again, this is very specific, very subspecialized, but I think if you do suffer from this, do keep on close follow-up with your gastroenterologist or colorectal surgeon, and you can be better advised with them.
Okay, hi. So yeah, I think the question is, what is the recommended screening frequency if one has had a polyp in a previous colonoscopy? So I think I spoke about this quite briefly previously. If it's usual small, low-risk polyps, we usually recommend a repeat colonoscopy in about 3 to 5 years' time, usually three. Of course, this changes where there are higher risk polyps when you reach they are larger, more than 1 cm, or there are multiple polyps in the colon. Of course, after the scope is done, if it says you'll be consulted again and seen with the results reviewed by your specialist, and they would then subsequently recommend when's the next interval. In those patients with multiple polyps or relatively large polyps, we may actually consider recommend doing a repeat colonoscopy in about 1 year's time, just to make sure that there's no recurrent growth or anywhere else. Yeah.
Okay, so the next question is, if one does the FIT screening test annually and shows some normal results, do we still need to go for colonoscopy? So the quick answer to that is no. So for screening purpose, FIT stool test and colonoscopy are complementary. So if you go for one and it's normal, you do not need to go for the other. But I say this in the context of screening. That means you're asymptomatic, you do not have any symptoms, and the whole purpose is just for screening for colorectal cancer. So in other words, if you do have any symptoms, for example, significant bleeding from when you pass motion, any acute changes, that means sudden changes to your bowel patterns, and or some unexplained loss of weight, loss of appetite, then in this case, in spite of your normal FIT results, I would still recommend for you to see a doctor or at least or a specialist for further review. Yeah, if you do have any symptoms. But otherwise, for this question per se, if you do FIT and it's normal and you have no symptoms, then you do not need to go for colonoscopy. Thank you.
So this question is on family history of colorectal cancer. The short answer is yes. We will recommend screening for everyone, especially with people with family members with colorectal cancer. In our current guidelines, screening for colorectal cancer starts at 50. But if you have a family member with colorectal cancer, do check at the age at which this family member had colorectal cancer. Start screening 10 years earlier than that particular age, or 50 years old, whichever is earlier. So, for example, if you had a family member with colorectal cancer at 55, you can start your colorectal cancer screening at 45, and that's recommended. Thank you.
Okay, so the question I'm answering is for colonoscopy. Do you remove all polyps seen? If not, is there a guideline regarding the size of polyp before you remove it? Routinely, when we do colonoscopy in SGH, based on what we see on the scope, there are certain characteristics which tell us how suspicious these lesions are. Usually, there are sometimes if it looks very benign based on the specific imaging patterns on the scope. Usually, we would tend to actually leave it alone if it's really very benign looking. But most of the times we will take it out, send it for since we're already there, it's a quick, simple procedure. We take it out, send it for testing, and then we can confirmatory diagnosis based on histology, where our pathologist will have a look. So short answer is we routinely will remove unless there's a specific indications not to. Yeah, hope that answers the question.
Okay. Oh.
Okay, this question is how often do we need colonoscopy? Some say 5, some say 10. So again, this one you need to discuss with your physician. In the general sense, 5 to 10 years is a good duration, especially if the first scope is normal. If there are any polyps found on your initial scope, depending on the type of polyps, number of polyps, we recommend depending on the type of polyps, can be 1 year, can be 3 years, can be 5. But again, the ideal number of years for a normal colonoscopy, 5 to 10 is a good gauge.
Okay, so I'm answering the question. Is daily use of a canned tuna bad? It's a very specific question. I'll take one step back. So I think that as what Dr. Kelvin and Dr. Wen has actually mentioned, the use of preserved foods actually is a known modifiable risk factor towards colorectal cancer. In specifics related to colorectal cancer, I think once you have a canned food, added preservatives, it is not ideal to our lifestyle. So I would say, with respect to colorectal cancer, if it's avoidable, please try to. Yeah.
Oh, okay, yeah. So this is a very good question, actually. What does it mean by change in bowel habits? Yeah, so I'm sure a lot of people hear this change in bowel habits as a red flag of colorectal cancer. But really, what does it mean? And actually, it's a very subjective thing. So what do I mean by that? So when we say change in bowel habits, it means that there's a sustained, very drastic difference in terms of your current bowel movement compared to before. So for example, maybe 1 year ago, you used to pass motion once a day, routinely, right? Or average on average speaking. But suddenly 1 year later, that means in this current time frame, you're now passing motion up to 5 to 6 times a day. And it's a sustained period over 2, 3 months. And it's not just like a 1 week affair and it goes away by itself. So that's really what we mean by significant change in bowel habits. Of course, our bowel habits can change from time to time because of our, for example, you go traveling, sometimes you go to a foreign country for a quick trip, and then your bowel habits will change a little bit. Or maybe because of the food intake, you have some, food that's not so hygienic, and then you suddenly experience a little bit of diarrhea for 1, 2 weeks. So really the key is drastic changes from what it was before and it's sustained. And if that's the case, then you should seek further advice from the doctor, whether it's a GP or you need to see a specialist for it. Hope that answers the question. Thanks.
If you do suffer from possible bleeding pulse, it is advisable to see a specialist first. Because in this state, I think the first thing we need to make sure is that there is nothing else other than the pulse, meaning that a colonoscopy would be indicated. Because if it proves to be colorectal cancer, then the treatment would be very, very different. Once that has been done, if the pulse is something that is bothering you, and with recurrent bleeding causing low blood counts or very bad symptoms, then yes, removal of pulse can be considered with its inherent risks of pulse surgery. And again, do seek help from your specialist to discuss further treatment plans.
Okay, so I'll be answering the question is how to prevent polyps from forming in your intestines. Unfortunately, I think this is something all three of us have alluded to in our slides. The formation of polyps is due to actually genetics, and it's something which cannot really be controlled or stopped. It's something that's congenital, and then it eventually develops over time and it slowly progresses. So unfortunately, I don't at this point in time, we don't have really means to prevent polyp formation, but we do have means of actually detecting them early once they have occurred. So that's where we have elaborated continuously about screening, colonoscopies, and then how early removal of these pre-malignant lesions actually helps prevent cancer. So unfortunately, we can't prevent it from forming, but at least we find it early. Hope this answers the question.
Very good question again. How to help family members who don't want to engage in active lifestyle and have high BMI is going to work and walking up the stairs consider exercise. Thank you. Yeah, so so actually a lot of my patients they do tend to have sedentary lifestyle. And what I often tell them is this: go out, get out of the house, go out and see the greens and the blues. When I say see the green, see the green grass, see the blue sky. Get out of the house, don't stay indoor, go out, enjoy the fresh air, go take walks in the parks, go down and walk around. That in itself is already a form of outdoor activity, exercising. Of course, the intensity will depend on the person, the individual's comfort level. But at the very least, get out of the house, see the green, see the blues. That's it.
I think as mentioned in Dr. Kelvin's talk, FIT is meant for someone who is asymptomatic as a part of screening. Of course, if you have done an FIT and it's negative, but you continue to have symptoms which include constipation, a colonoscopy can be considered, as after all, colonoscopy will be the gold standard test for diagnosing lesions or cancers or polyps within the colon. Thank you.
So the question I'm answering is review mandatory after 5 years, and what precautions should I take note? Okay, so thank you for this question. Unfortunately, the thing I need to know is during the review previously on during the last review, what actually was found and what was seen on the scope. Usually what happens is in Singapore, we will actually suggest to actually repeat a colonoscopy for screening once every 5 to 10 years. In our institution, if we do see someone and have done a totally normal scope, absolutely normal, we will actually discharge the patient, giving them a letter or memo to come back in 5 to 10 years time for consideration of a repeat scope to make sure that in 5 to 10 years, no new polyps have grown, nothing else has, or something more sinister has grown underneath. So I would strongly suggest doing so. Even if the previous scope was benign, and then at least get a quick scope, get it done, at least have the peace of mind after that. Yeah. Hope this answers the question.
So the next question is, if there are polyps present during last colonoscopy, is it safer to go for 5 years? That means I assume it's repeat colonoscopy 5 years after, and until what age? Thanks. I think this question has been answered to some extent by our previous speakers and also covered to some extent in our talks. Just to recap a little bit. So I think one thing we need to take note of first is it's not necessarily a blanket rule for everyone. You also got to look at the specifics of your case. So for example, what do I mean by that? For example, how many polyps were present in your last colonoscopy and what kind of polyps were present? Is it like so even when we talk about benign polyps, actually there's still some sort of stratification as to, is it like a low risk kind of benign polyp or is it like a higher risk kind of benign polyp? Because the fact is, if you do have more polyps present at the first scope, or if the so-called benign polyps will belong to a slightly higher risk kind of benign polyps, then you may need an early repeat surveillance scope in, say, 1 year or 3 years after the initial scope. So there's some individualization to be done in accordance to your specific case. And this has to be done in consultation with the specialist. So there's no specific blanket rule to cover for all members of the public. You really got to see the individual details and what kind of polyps were present. Yeah.
Oh, thanks for the question. This is a very good question. We recommend screening for colorectal cancer at 50 because there is a spike in number of cases of colorectal cancer from 50 years old onwards. But that is not to say that one cannot be diagnosed with colorectal cancer younger than 50, although a very, very small percentage. We are looking at maybe a total of 1% of all the colorectal cancers diagnosed in Singapore in members that are less than 50 years old per year. However, if you do have family members who have a very strong family history of colorectal cancer developing at earlier age, I refer back to my earlier answer is that if let's say they get diagnosed at 55, the family members should get screened earlier for colorectal cancer 10 years before this age. So at 45, you should start considering screening already at that point in time. Thank you.
Yeah, so we're answering the question, is clay-colored stool a cause of concern for colon issues or liver issues? Is regular constipation a cause of concern? So clay-colored stools usually isn't related so much to colorectal issues. We're usually more worried about bleeding, whether there's a gross blood seen or really altered blood, which is a bit more maroon-colored. Sometimes clay-colored stools may not definitely, but may actually represent some form of pancreas or liver issue. But that one usually probably get checked out by your specialist first beforehand. Is regular constipation a cause for concern? I think that what my previous speakers have also mentioned, in the end, it's not so much about it's more importantly, what has been your normal baseline. If your baseline has been passing motion once every 3 days for the past 30, 40 years, and there's been the similar since young, honestly, I think wouldn't be too concerning. But of course, if it's a sudden change, where all of a sudden we used to pass every day, and all of a sudden now you only pass motion once every 3 days, once every 4 days, that would be more concerning. So I think it's more of the change that is more important. Yeah, I hope this answers your question.
Okay, very interesting question. Does probiotics help in prevention? So I assume in this case it's prevention of colorectal cancer. Okay, so I'm aware there's like some small scale studies that purport that probiotic helps to change the the kind of bacterial flora within your gut, and so helps to mediate the immunity within your gut system, and so may be beneficial in preventing colorectal cancer. And probably some of the drug companies will even go as far as to proclaim that it does help in preventing colorectal cancer. But my answer to this is that there's no robust data to show conclusively that probiotics help in preventing colorectal cancer, which is why I didn't mention it during my talk earlier. So I think officially there's no conclusive data, and we cannot recommend probiotic as a means of preventing colorectal cancer. Thank you.
Okay, the question is about colonoscopy in the elderly. The screening start point, I think we have reinforced many times throughout this talk at 50 years old. But whether for an elderly patient, whether they are fit for colonoscopy depends on the assessment of the patient also. If a 70-year-old elderly is very fit with no other medical problems, then yes, we would still recommend proceeding with a screening colonoscopy. So 5 to 10 years, again, I think we have also answered that. Depending on the findings of let's say they do colonoscopy at 70, depending on the findings, what polyps that we find or we find anything else, then the recommended interval will be given to you at follow-up consultation. But generally speaking, screening colonoscopies, we do say that at 75 and above, if the last scope at 75, for example, was normal, then there is a reduced impetus to continue offering repeat colonoscopies given the age. But again, case by case basis, we need to assess the patient one at a time based on how they are at the baseline. Thank you.
Hi, so today I'm answering can colonoscopy stop after 75 years of age? So again, I think it's a similar question posed to Wen Xie previously. Again, it's more of the weighing the pros and the cons and individual needs basis. If, for example, if it's purely screening colonoscopy and this specific patient has maybe heart conditions which require blood thinners, or like lung conditions, heavy smokers previously, we have higher risks to undergo sedation for colonoscopy, then we would tend to actually veer towards maybe not performing the colonoscopy because the risks outweigh the benefit. And at the same time also, we have to start thinking what's the last scope? Was there any other high-risk features? And what's his functional status beforehand? If he's already like bedbound or already on a wheelchair, would this really benefit the patient that much? So similar answer to difference here. In the end, it's a case-by-case basis. We raise the pros and cons.
Okay, wow, this is a very technical question. So obviously the person who posed this question has very good knowledge of how colonoscopy is done. So do surgeons examine the ileum when they perform the colonoscopy? So I think it depends in part the purpose of the scope. So for example, if you're doing colonoscopy for the purpose of screening of colorectal cancer, there's no need to examine the ileum. So we do not routinely examine the ileum when we're doing a scope for the purpose of screening for colorectal cancer. But there will be some cases, some situations where we will routinely examine the ileum. For example, if there's any suspicion or in a person with known inflammatory bowel disease, we will actually examine the ileum. So this is more of a technical issue. But again, I mean, in the context of our talk today, where we're talking about colorectal cancer, no, we do not routinely examine ileum for the purpose of screening of colorectal cancer. Thanks.
Okay. Hi, everyone. Today, I'm Dr. Liner. Also, thank you all the panelists for giving such a wonderful talk and informative talk on colorectal cancer in our country, what it means to go for screening, and how is it diagnosed and how is it treated. This year marks actually 35 years of SGH fighting colorectal cancer. This is our 35th anniversary, and usually we conduct this talks in the month of March as part of our colorectal cancer awareness month. But in line with our anniversary, we are trying to increase the awareness and public outreach of colorectal cancer screening, and therefore we chose to actually give an additional talk this year. So we have spent 35 years fighting colorectal cancer. It is, as what we have mentioned earlier, is very treatable if it's diagnosed early. It is one of the most common cancers affecting people who are older than 50 years of age. And in the year from 2017 to 2021, each day, 6 to 7 new cases are diagnosed. And unfortunately, 2 to 3 people die of colorectal cancer every day. And this is despite us introducing a national colorectal cancer screening program in 2011, where the screening uptake in our country, based on a recent cohort study, remains low at 27%. And despite this, 60% of them are still being diagnosed with stage 3 and stage 4 advanced disease. So at SGH, we are the largest colorectal cancer screening center in our country. We perform the bulk of the colonoscopes in our country, and we continue to push the boundaries of minimally invasive and robotic colorectal cancer surgery, as what was described by Dr. Lin Wenjie. We have also have reduced the length of hospital stay for our post-operative patients from 10 days in 2016 to 5 days in 2023. We will need your help to continue our journey in the next few years and the next decade, to continue the breakthroughs in pushing the boundaries of diagnosing cancer early, treating and improving the outcomes for our patients. So please join us in helping our department in fighting colorectal cancer and improve the lives, not only the patients, but their loved ones. So, in line with our 35th anniversary, we are actually putting up this fundraising campaign called the Stand Up to Colorectal Cancer campaign, whereby we actually hope to raise not only just awareness and outreach for colorectal cancer, but to also improve the outcomes for our patients. And this is through raising funds to help seed initiatives, to do studies, to help to reach out to communities that cannot afford colorectal cancer screening, and also to help to look into improving the quality of life, not only just their survival of our colorectal cancer patients. So do help out, raise the awareness, spread the word on our own fundraising campaign, and we hope to scan the QR code here, whereby you can donate money for our campaign that will last to the end of this year. Thank you. I'll now pass the time on to Prof. Emil to conclude our webinar. Thank you.
Hey, thanks, Lionel. Thanks, Kelvin, Aaron, Wenjie as well. Then most of all, thank you to all our participants here today. We hope it's been an informative session. We do hope that we get to see you in our clinics, screening for colorectal cancer and making sure to trust us with your health. Thank you once again, and a very good morning and good weekend to everyone. Bye-bye.